You can get hematuria with both bladder stones or kidney stones. In this case, she didn't even have hematuria, but she had microscopic blood. So microscopic hematuria, which is something that you can get with kidney stones, bladder stones, all sort of stones, because they'll injure the tract as they're passing down. So that's why when you're doing GP or something, if you're dipping and you find blood, you're very suspicious of kidney stones. Yeah. And then also in this case, the pain was from her right loin to her right groin, which makes more sense with renal calculi rather than bladder calculi. Bladder calculi, the pain would have been more suprapubic and more localized to where the bladder was, because it wouldn't have had to pass down that tract. So that's where the pain would have been centered. But both of them, you can have hematuria, microscopic or frank. Okay. Okay, the next one, a 30-year-old male is unconscious on admission following an RTA. He was a driver of the car, and there's a suspicion that he was responsible for the accident in which a passenger of another car died. In attendance with the patient is his wife, who was uninjured in the accident. The police are keen to obtain a blood sample for alcohol measurement, but the patient's incapable of giving consent for this procedure. And there's no forensic physician who can do so. So you're working in A&E, but are not directly involved in the clinical care of this patient. The police have asked you to obtain a sample of blood for analysis. The clinical team who are looking after the patient are aware of the request made to you by the police. Which of the following is the most appropriate action in these circumstances? And so it's like an ethics question. So would you refuse to obtain a blood sample until the patient is competent to provide consent? You can't do that, because what if if they're looking for alcohol, if they're looking for toxins, they might be gone by the time that the patient comes around and is able to provide consent. So that's not ideal. Next one, obtain consent from his wife as next of kin to draw the blood sample. You can't do that, really. You can't obtain the consent from someone else, especially if he's going to come around eventually. Inform the police that you may only take blood samples on medical grounds. The police can actually ask you for blood samples, so that doesn't mean, and they want to look for toxins and stuff, so not really. Draw a blood sample which can be analyzed immediately. Again, that's not, you can't do that because you haven't obtained consent from the patient, or you haven't to analyze the blood. So draw a blood sample for later analysis when the patient's competent to consent. You can do that. You can take the blood but not analyze it, just keep it. So when the patient comes around, you can ask if they're able to run the blood tests. That sounds like the most ideal. So there's clear guidance on blood specimen taking from incapacitated drivers. So according to the document, a blood specimen can be taken for future testing for alcohol or other drugs from a person who's been involved in accidents unable to give consent, where police believes the person's incapable of giving valid consent due to medical reasons. A forensic physician can actually say, yes, you can take the bloods and you can analyze them there and then. They can take that action, but in this case, they didn't have a forensic physician. And it's a requirement of the legislation that before the specimen is taken, the doctor in charge of the patient's care has been notified of the intention to take blood and has not objected on the grounds that such action would be prejudicial to the patient's care. And the specimen may not be tested until the patient regains competence and gives valid consent for it to be tested. So that's what we're doing. And a person who fails to give permission for the testing without reasonable excuse is guilty of an offence. And the police have no powers to take and test blood specimens that were taken as a part of the patient's care in hospitals. So you can't add on blood tests to blood that was already taken. And following the Police Reform Act, it's no longer necessary to obtain consent from unconscious or incapacitated drivers. However, the sample is not tested until they regain consciousness, and then consent is taken for it to be tested. And a competent person who refuses to allow his or her sample to be tested will be liable for prosecution, and the new law recognizes this duty to justice. So basically, you can take the blood sample, but you just can't run it until the patient comes around, and then you can get consent to run it. If they don't consent, then they're acting guilty. Okay, next one, which one of the following deaths should be reported to the coroner? So 52-year-old male with a history of hemochromatosis admitted with confusion and dies 2 days later with hepatic failure. So everything checks out, so you wouldn't really need to refer him if everything checks out. So he had hemochromatosis and he died with liver failure. Okay, the next one is 62-year-old male with a 2-year history of severe dementia, admitted from a nursing home with fever and breathlessness, dies 3 days later with pneumonia. So that fits again. He had a fever and he had breathlessness, and the diagnosis with pneumonia, which is what he died with. Then the one after, a 69-year-old male with pneumoconiosis. So pneumoconiosis, occupational lung disease, any occupational related death are referred to the coroner. So that's already, this one's going to be referred. Admitted with fever and breathlessness, and he dies 2 days later with pneumonia, you're still going to refer him just because he had a history of occupational lung disease, the pneumoconiosis. But let's just read the rest of them. A 70-year-old male, myocardial infarction, dies 48 hours later, fine. And a 73-year-old female who's undergone a hip replacement 2 months ago and now presents with severe chest pain and breathlessness. She's diagnosed with PE but dies. That's expected after a hip replacement. It's not something that's odd or out of nature. So the one, because she must have not been immobilizing, there's risk factors there. It all adds up. But this one, because of the occupational lung disease, you defer to the coroner. So pneumoconiosis, occupational lung disease, because of the family may be entitled for compensation, especially if there's thought to be a reduction in the length of quality of life because of it. It has to be referred or discussed at least with the coroner. But the cases that are usually referred, cases where the cause of death is not known, the deceased was not seen by the certifying doctor either after death or within 14 days before death. The death was violent or unnatural. The death was due to an accident. The death was due to self-neglect or neglect by others. Death was a result of an industrial illness or due to a person's employment, in this case, the pneumoconiosis. The death was due to an abortion. The death occurred during an operation or before recovery from anesthesia, and the death might be due to suicide, or if the death was occurring shortly after being taken into police custody, or if it's because of acute intoxication with alcohol, drugs, or substance misuse. So all these need to be referred to coroners. Okay. So a mother brings in her 10-year-old child who displays convincing signs and symptoms of meningococcal meningitis. You wish to administer intramuscular antibiotics as a matter of urgency. You explain this to the mother, but the child refuses to allow you to administer the injection. Both the nurse and mother physically restrain the child and ask you to give the injection. Which of the following is the most appropriate action? So again, this is an ethics question, but he's a 10-year-old child and his mom's already given consent for him, and it's life-saving because meningococcal meningitis is quite serious. So you would give it because it's in his best interest. So that would be the correct answer. You wouldn't assess his capacity or refuse to administer. He's only 10 and his mom's given consent already. Okay. Whilst inserting a peripheral cannula during a cardiac arrest call, you manage to sustain a needle stick injury. You successfully cannulate the patient and send off a full set of blood. Unfortunately, resuscitation is unsuccessful and the patient dies. You follow local protocols for immediate care of the needle stick injury and then consider the patient's infection status. Which of the following is the most appropriate action? As the patient is dead, it's not possible to carry out an infection screen. That's wrong because you can actually carry it out even if they're dead. Ask the patient's friend who is visiting. No, that's already inappropriate. Inform occupational health department of the injury. Yes, you'd want to definitely do that. All injuries, whether alive or dead, you would want to get in touch with occupational health to discuss that you've had an injury and you need to take consent. Sometimes they do the consent taking for you. But yes, request an infection screen from the bloods you have taken. Not yet, you need to discuss it with occupational health first, and request an infection status of the bloods that the laboratories already has from that morning. So again, you discuss it with occupational health first. Sometimes they do it for you. So yeah, consent is still required even if they're deceased. It has to be obtained from their next of kin, even if the lab has the samples already. And needle stick injury should be recorded in an accident book as a critical incident form. I'm sorry, I got some work to do. The mocks will be available for later time to revise for the mistakes. I'm not sure if this is recorded and put somewhere. Let me just ask. Sunder. So I'm not sure if this will be recorded, but either ways, I'm sure the mock results with actual explanation of the questions and the answers will be up eventually if they're not already up. Okay, so yeah, so they'll be available later after the editing. So that's great. Okay. The next one was a 22-year-old female who was admitted following severe injuries that were sustained in a road traffic accident. She's communicative but in shock with low blood pressure and tachycardia. You realize that without a transfusion she will die, but she informs you that she's recently become a Jehovah's Witness and that she adamantly refuses transfusion despite knowledge that she could die. She's able to understand this and communicate her decision back to you. Her distraught parents tell you that she's only recently joined the Jehovah's Witness and implore you to transfuse her, as they insist that she doesn't know her own mind. Together with other intervention which she permits, which is the most appropriate action regarding possible transfusion? So again, sort of an ethics question. She's 22. She clearly is capable of making, her own decisions, and she's just become a Jehovah's Witness. So you'd have to just respect the patient's wishes and not transfuse. Do not transfuse. So that you wouldn't transfuse in this case, because that's what she said. At the end of the day, it's the patient's wish comes first. So she's competent and she's elected to refuse the transfusion. So despite her parents' protests, you can't, unless she changes her mind. Next, you had a 77-year-old female who's on warfarin for AFib, who comes in with melena. Her blood pressure is 90/60 and her heart rate's 100. Her investigation show and her hemoglobin of 90, MCV is 87, INR is 7.2. A PR examination confirms melena. What's the best option for correcting the coagulopathy? So in this case, because she's having melena and she's had a drop in hemoglobin and her INR is raised, melena is a big bleed, and her blood pressure is low, you'd want to stop the warfarin. You want to give vitamin K, and because that will take time to kick in, you want to also give a prothrombin complex concentrate. She's hypertensive and she's tachycardic with melena. That's a big bleed, so in those cases you give them prothrombin concentrate as well. Okay, the next one was a 35-year-old woman who's on warfarin after suffering a deep vein thrombosis, who presents with an INR of 8.2 and conjunctival hemorrhage. The blood pressure is fine, 125/55. Her heart rate is also fine, 65. ECG is normal sinus. What's the following most appropriate treatment for this patient? Because she's stable, her blood pressure is fine and her heart rate is fine, and she's only had a minor bleed, conjunctival hemorrhage, you just give oral vitamin K in this case to reverse it, and you'd stop the warfarin as well. Just stop the warfarin and give oral because it's a minor bleed. Okay. Okay, a 20-year-old actress had generalized lymphadenopathy and splenomegaly. She's diagnosed as suffering from acute myeloid leukemia. Which is the most likely cell of origin? So yeah, with myeloma, with acute myeloma, acute myeloid leukemia, it's why not to stop warfarin? Because if you stop the warfarin only, you're still not going to correct the INR or actually or reverse the effect of this of the warfarin. So you have to give vitamin K as well. But if it said stop warfarin and give oral vitamin K, then yes. But for her, you need to stop it and give the vitamin K, because this is the thing that's going to fix everything, reverse everything that's just happened. And then you can start with either a lower dose or whatever, depending on the INR once it's corrected. Okay, so this one, she's diagnosed with acute myeloid leukemia, myelocyte precursor. So that one is straightforward. Okay, the next one, you have a mild lymphocytosis of 15 with a few smear cells reported on full blood count result in a 70-year-old asymptomatic man attending clinic for an annual review. Which of the following would be the most essential investigation to establish a diagnosis of chronic lymphocytic leukemia? So the blood flow cytometry with CLL, it's mainly the type of cell. So blood flow cytometry will tell you which type it is. If it has CD19, CD23, which type of, is it B cell or is it T cell? So that would be the one that you choose for lymphocytic leukemia, chronic lymphocytic leukemia. A CT scan and LDH are needed to complete staging, but they're not essential for diagnosis. Smear cells are reported in other lymphoproliferative as well as benign lymphocytosis, which are, they smeared on the glass slide. Cervical lymphadenopathy may be seen in CLL, but can also be seen in any other cause of lymphadenopathy, so it wouldn't be specific in this case for him. Okay, the next one you had a 43-year-old woman who presented to the clinic with increasing lethargy and fatigue. She's been treated previously with interferon alpha and has diagnosis of CML. Her white blood count has risen to 22, and she's anemic with a recent hemoglobin of 89. You decide to start her on imatinib. Imatinib, which of the following correctly describes the mode of action of imatinib? So it's BCR-ABL tyrosine kinase inhibitor, which is the one you use for CML patients. Okay. 66, you have a 35-year-old first-time donor who suddenly passes out as she's donating blood. Which of the following steps would be the least useful in managing this adverse event? So ensure the donor is adequately hydrated, does not skip a meal. So the least useful, ensuring that she's hydrated and not skipped a meal, is okay. Elevating the donor's legs, as this is usually due to vasovagal syncope. Fine. Hemoglobin, if the donor meets the minimum requirement for donation. The donation is usually continued along with simultaneous normal saline infusion. So no, you'd actually want to stop the donation, and you'd want to get her legs up and make sure she's hydrated and all the other things. Encourage to mobilize after they've recovered. But you wouldn't continue if she's starting to feel dizzy and passes out. It's inappropriate. So the next one, you have a 55-year-old man who's being reviewed for an elective cholecystectomy in the preoperative clinic. He has no comorbidities apart from 2 attacks of cholecystitis in the last 12 months. He's never received a blood transfusion in the past. The request for the blood bank should include which of the following? So because it's an elective procedure, and he's not had a blood transfusion in the past, it's unlikely that he's going to need blood this time because it's elective. So you just do a group and save, which is where they find out his blood type and they save it ready if he needed a blood transfusion. But if it was an emergency procedure or if he needed a blood transfusion in the past, then it would be group and save and cross match. But because it's elective, he's not going to need it at the moment, and he's never had a blood transfusion in the past. It's just group and save for now. Okay, so group and save is adequate for elective surgeries and is a standard practice in most modern blood banks. It'll involve blood grouping and its confirmation as well as an antibody screen. Other options include cross-match and a direct Coombs test, like a direct antiglobulin test or DAT, but they're only done if the antibody screen is positive, and they're not routinely done for elective surgeries unless the patient had, a recent blood transfusion or a history of previous red cell antibodies. Yes, I think they're part of the mock. I think they'll be part of the report with the answers. I'm not sure, but I'm assuming. Sunder, would you be able to message that? Yes. So they'll be in part of your report with your mock outcome. Okay. So the next one, you have a 40-year-old lady who's planned for a day case in growing toenail excision. She has a body mass index of 37. She's overweight. She's otherwise completely fit without any past medical history, significant family history, or medication. There's been no recent travel, which is the most appropriate management prior to surgery? So because it's just a toenail excision, she doesn't actually really need anything. If it's going to be something that was going to cause immobilization or risk of infection, then you would consider all the other things like antibiotic or TED. So in this case, no medication required for the time being. It's just a toenail excision. Okay. The one after it is a 35-year-old woman who presents with easy bruising and bleeding from oropharyngeal, vaginal, and lower gut mucosa. Her prothrombin time, platelet count, and function are normal, but her APTT and bleeding time are prolonged. What's the most appropriate investigation? So 35-year-old woman, easy bleeding, and you're expecting, with the bleedings from her oropharynx, vagina, and lower gut mucosa, everything's normal except the APTT and bleeding time. So you're expecting something like factor VIII or von Willebrand. Factor VIII would be, if it was a man, you'd be suspecting, factor VIII deficiency. But in this case, it's more von Willebrand disease because she's a woman, so you do factor VIII antigen. So von Willebrand disease, most common inherited bleeding disorders. It's inherited in autosomal dominant pattern. You can get mucocutaneous bleeding when von Willebrand factor is low. Common presentations include bleeding of the gums when brushing them or heavy menstrual bleeding. pregnancy, oral contraceptives, and liver disease all increase von Willebrand factor levels, and in such situations, repeating testing is necessary. And then you have the 4 different types of inherited von Willebrand disease, and it can be acquired with certain diseases like lymphoid malignancies, or lymphoproliferative or myeloproliferative disorders, or autoimmune disorders. Some medications can also cause it, like sodium valproate with epilepsy, that can cause von Willebrand disease. Okay, so another one, a toddler who has von Willebrand disease is admitted after a fall from his bicycle. He has hemarthrosis of his left knee and bruises on his right lower leg. Which transfusion is indicated in this case? So it would just be a factor VIII concentrate. He's got von Willebrand disease. He's had a fall after his bike. Now he has hemarthrosis. The one thing that he's missing would be the factor VIII concentrates. So factor VIII concentrates would be the treatment. So with patients with von Willebrand disease, you either give them desmopressin, so DDAVP, and the von Willebrand factor. And desmopressin, what it does is it encourages the endothelial cells to release factor VIII. And von Willebrand factor containing factor VIII concentrate transfusion therapy. Fresh frozen plasma contains functional von Willebrand factor, but should be avoided whenever possible because of the potential transmission of viral disease. And additional drawback of fresh frozen plasma is the large infusion volume that you need, whereas with factor VIII concentrates, it's much easier because you're just giving them exactly what they're missing.